Oh, wow. It must be nice to finally see each other after more than 2 years of not being able to say hello. Probably that's why it's taking us a bit of time to settle down, and it's totally understandable. Now, a very warm welcome to you all, ladies and gentlemen, to our first in-person Lives in the Balance event. That's a big deal. That's a big deal. I mean, the Lives in the Balance Summit were born at the height of the pandemic, right? And they provided a beautiful opportunity for us to converge, for us to meet, for us to learn, for us to collaborate, for us to act. 4 virtual events later, thousands of us meeting online and over Wi-Fi, and now here we are. It's beautiful. And you know, I'm a hugger by nature. Yeah, so you probably can tell how much this means for me. And I just have to publicly apologize for any person who we've been communicating and interacting online, and then I met you within the last couple of days, and hope I didn't break any bonds. Yes. So welcome for those who are joining us online. Thank you so much for being here. And how apt is it that we are doing this just a few weeks after the COVID-19 was declared to be no longer a public health emergency, right? What does that mean? What does that mean? What does that mean? Does it mean we are out of the woods? Oh, wow, that was so quick. What does that mean? What does that mean that the COVID-19 pandemic is no longer a big thing? Are we safe?
Yes.
Are we safe?
Safe.
Safe. Are we safe?
Safe.
Oh my goodness. Are we safe?
No.
Are we safe?
No.
How many are saying yes, that we are safe? We are not out of the woods. Listen, we cannot forget that during the pandemic, 10 million children lost a parent, lost a caregiver. We cannot forget the fact that in 2021, 5 million children died before their 5th birthday. We cannot forget the fact that during the pandemic, the thousands of our young people who just came out and said, you know, I am depressed, I am anxious, I have things going on that I need to talk about. It just went up. We cannot forget about the thousands of women who had to live under the same house with people who violated them in a way or the other in the name of COVID restrictions. And we are not out of the woods, good people, because of the damage that the pandemic has left behind, which we still have to deal with. But that aside, there are other things that are here: climate change, conflicts, the cost of living. You know, today, fighting in Sudan enters its 6th week. And for a country of 45 million people, only 29 hospitals are functioning. In under 6 weeks, the country has been reduced to deal with that. 45 million people have to survive with 29 facilities. Today, we are seated here talking about all these things. There's a woman, true story, who has given birth in the back of a truck, fleeing war somewhere. So we still have a long way to go, and I am so glad to see that we are all here. And you know what I call these sessions where we gather, and the boardrooms where we sit, and all these, the World Health Assemblies? It's a fueling station. That's what we have come here to do. We have come to fuel, to recharge, to gather what we need, and go on. Because there are millions of our women, our children, our adolescents who still need our support, who we have made promises to halfway to 2030, road to 2030, that we have not delivered. And you know, some of you here made those promises in 2015. You took part in the SDG thing, you've taken part on all these campaigns. Yeah? Are you happy? Are you happy? Thank you very much. My name is Mercy Juma. I am the BBC News East Africa correspondent. And apart from that, I am a big champion for women, children, and adolescent health and well-being. And that's the reason why I'm here today, because we have work to do. And after this session, and after the 2 other Lives in the Balance sessions we have, we will have enough fuel to take us on to the next year, and then we come back and take stock. So thank you for being here once again. We have a wonderful panel that is sitting here that we will get into after a while, but before that, I want us to watch this video. It's called Protecting the Promise, and then Helga Fogstad, the Executive Director of the Partnership for Maternal, Newborn and Child Health, the amazing host for this event, will give her opening remarks. Thank you.
Dear partners of change, welcome to this series of 1 out of 3 events, which are key. I must say that we are gathered here in a critical moment where numbers are at best plateauing, going back, and this has happened because of COVID, this has happened because of conflict, this has happened because of climate change, and it's happening on our watch. And it makes us so sad, and we are needed more now than ever, because no one partner, no one constituency can do this alone. So PMNCH's mantra, which is getting constituencies from governments to private sectors, adolescent youth organizations together in order to do more than they can do alone, is critical right now, because there are a lot of challenges to actually address. And we will hear about them today, and we will see together how we can follow up from PMNCH's side, commitments at country level, ensuring that there is better alignment, and ensuring that GFF and other institutions and mechanisms can really yield what they are intended to then do. So this is something that we are very passionate at PMCH. Please become a member if you're not, and see what you can do through your constituencies, and then we will then take stock and really follow up. So this is not an event, it is a milestone. So please keep that at heart and follow us. Over to you, Mercy.
Thank you very much, Helga. And now we're going to have our remarks via video from Dr. Tedros Adhanom Ghebreyesus, the Director General of the WHO.
Excellencies, dear colleagues and friends, no mother, child, or adolescent should die from preventable or treatable causes, but millions do every year. Where you live, your gender, and the resources you can access should not determine whether you live or die. A combination of COVID-19, conflict, climate change, and the cost of living crisis have exacerbated setbacks in maternal, child, and adolescent health. WHO and our PMNCH partners have critical roles to play in supporting governments to reverse this trajectory. In the past year, WHO has updated guidelines on family planning and developed recommendations to improve outcomes for small and sick newborns and the quality of routine postnatal care. With partners, we have established the Global Accelerator for Pediatric Formulations and published a definition and framework for adolescent well-being. These efforts and more are part of WHO's global strategy for women's, children's, and adolescents' health. In a time of constricting budgets and curtailing of rights, we must all advocate for investment in strong and equitable health systems built on a foundation of primary health care and universal health coverage. Every woman, child, and adolescent should have the opportunity to survive and thrive. I thank you.
Thank you to Dr. Tedros in absentia, but who is a very big champion of women, children, and adolescent health. And now, Bruce Elwood, Assistant Director General, Universal Health Coverage, Life Coast WHO. Really nice to see you in person.
Thank you. Can I borrow your mic?
Sure.
I'll shake your hand as well. I'll give you a hug. How about
I
that?
love hugs.
Yeah, you're a hugger. So, Mercy, thanks. Folks, everyone always stands up and says, I'll be brief, and then they go on forever. But as my boss just spoke, I think I have to be. But normally, if I've learned one thing in WHO in 30 years, you never speak after your boss. The boss gets the last word. But on this occasion, we just felt, look, it's such an important issue that we're dealing with. I'm brand new to this role, so I'm just getting to meet many of you and relying very heavily on a bunch of superstars in my own team, like Anshu, who's here somewhere, and various others. But I just wanted to reaffirm in the flesh our own commitment to this agenda. This is the first event that I'm taking part. Oops, I'm not supposed to say that either. I went to the opening ceremony. That was the first event, and the walk the talk before that. But the first side event that I'm getting to be part of. And it's so appropriate because this is such a crucial agenda. You all know it better than me. And I was struck by the title when I saw this at the beginning, Keeping the Promise. And then so I had to go find Helga and Anshu and ask, what was the promise we made? And I realized we've not kept the promise at all, with 800 women dying every single day, if I have my numbers right, from pregnancy or complications of trying to have a child, and then 54 countries off track on under 5, a very, very doable target. And then with newborns, 60 countries, even more off track. So we haven't kept the promise so far is the bottom line. And I'm going to be a bit of a downer here and say, look, it would be fabulous if we could say this is because of COVID. It'd be great for me. I could blame COVID and then watch everything go up and we'd be in great shape. But, you know, when we look in our hearts of hearts, as I think everyone in this room knows better than me, we were in trouble before COVID hit, and we were in trouble as far back as a couple of years before COVID hit, which means a couple of things. Number one, we can't blame COVID. Well, we can still blame COVID because most people don't know the numbers, the realities, but it means the task is that much tougher because we're coming out without that progress, and we're coming out with scarred health systems. Health workers have had the worst few years of their lives. Health systems are scarred. And what we're trying to do now in the face of that, and Mercy, you bring your great energy to getting us moving, but the reality is people are tired, and getting them moving on this agenda is going to be tough as well. And I think the third risk that we have is thinking it's simply a matter of doing more of what we already know. And the little bit of time that I've had on this agenda already, actually, that's not going to be enough. We do have to scale up the stuff we're behind on, the interventions that save lives that we all know about so well. We do need to look at some new things that haven't been introduced in many, many countries, especially in the area of newborns. Super interesting stuff. We can save lives there with some simple interventions. And then we have got to also, though, be looking at some course corrections. On maternal mortality, we can't be up in the 200s with a target of 70 and think we have the toolbox to get us there the way we're thinking today. We still have got to make some, we can get a long distance, not a reason not to do what is in front of us, but we clearly need to be thinking a bit more. And that's part of the reason I thought that this set of roundtables, just fabulous, or panels, what are we calling them? Roundtables, panels? Dialogues. But we're calling this one a panel. And dialogues. But with 3 of these over the course of a few days here during the Assembly, with partners all present, right? So important. Lots of important discussions at the Assembly itself, but the reality is it's going to take the power of partners, a lot of whom aren't in the room there to move this forward. So important events like this. So important that we're going to spend a whole one looking at maternal mortality, the whole one again looking at children, adolescents. So just wanted to thank PMNCH, and just from our side, from the WHO side, we will be a great partner going forward on this agenda. At the global level, we have a super important agenda on the normative work. We're not quite there on all of it, and these are tough normative areas, but we've got great people, and where we have gaps, and we have lots of them, we have great partners to work with to get solutions there. We have great people in our regional offices, deeply committed to this agenda and take it forward with you, and of course, at our country level as well. So we'll be a great partner. We say thank you to our PMNCH colleagues and Helga, who I now work with on a daily basis, or will be as we go forward. And again, a special thanks, Excellencies. I'm almost supposed to start with Excellencies. And please, Secretary, don't tell Dr. Tedros I didn't start with Secretary's all protocols. But we are off-site right now. But a chance to just thank you for coming and giving your weight and your authorities and your insights to this agenda, because frankly, it's a political agenda as well. It's a technical agenda, but it's a very, very political agenda. A lot of tough issues in here, and we need a lot of tough politicians and ministers and secretaries with us on it. So your just being here is, I think, part of what is so important to this partnership, and thank you for joining us. With that as well, we're going to hear a panel talk about the solutions. You'll notice I talked only a little bit about those. I'm very much on a steep learning curve, here to listen, here to learn, and we will take forward, especially what we hear from the countries, as this is how we did it, because that's going to be the key. Thank you very much. Mercy, back to you.
Thank you. Wow. You know, it's really interesting to see to hear Bruce saying that probably we are blaming COVID too much. Yeah, because these things were there with us. And I said this last week, and I'll say it again in this audience. My mom is a midwife. She's 72 years. She is set to hang her boots in August this year. She was in government, then went to private practice. And growing up, ever since I was a child, I was so used to, see her being called in the middle of the night. There's a woman who's going to deliver. There's somebody who needs you. There's a girl who is in labor because she works in rural Kenya, Doc. Yep. And when I was preparing for all these events, she told me, you know what? I have been in practice for more than 45 years. 45 years, the same things that used to kill mothers and children and girls when she started practicing are the same things killing them today. That's immoral. There's no better way to describe it. It's immoral. And I hope that, I don't really get to discuss these same things with my 6-year-old daughter when she's 10 and tell her that we spoke about these things in Geneva in 2023, and then we are speaking about them now. We are the people to create a movement, and thank you for being here. Our wonderful panelists, really, really glad to have you here. Thank you so much. Minister of Health for South Africa, Mr. Matume Joseph. And then we also have Wilhelmina Jala, Minister of Health for Liberia. Thank you so much for being here, ma'am. Leah Tadesse, Minister of Health for Ethiopia. Welcome. Mariam Galawi, really nice to have you here. Mariam is the Liaison Officer for Human Rights and Peace Issues at IFMSA, International Federation of Medical Students Association from Tunisia. A round of applause. And lastly, Luke Laviolate, Head of Secretariat, Global Financing Facility for Women, Children and Adolescents, GFF. Okay. Yes, so that will be the panel that we will be talking to shortly. But before that, did I miss something? Anybody with a program? You're doing great, Mercy. Yes, the keynote speaker, Xavier Becerra. Really nice to have you here. Please, the stage is yours. Thank you so much for being here. Do I get a hug?
Mercy, thank you very much. And you have a distinguished panel, and so I will be brief. I will simply begin by saying thank you to Helga and all the work that's being done by PMNCH over the years and now especially. I want to speak to you briefly as you prepare to hear from panelists about where we are in the United States, because I believe that if we are going to get back to where we should, if we're going to deliver on that promise, the United States will have to be there in a big way. And so I simply want to say a few words to express the feelings of our president and our vice president and our administration today and our team that is here in Geneva working with so many of you on many of these issues. It is a privilege to be among distinguished panelists who have worked so hard on this issue. Our health at home, and I mean your home, my home, our home, is irrevocably connected to the health of all of us, everywhere. And we're committed to making sure that all people can access the health care they need, not just in the United States, but everywhere. Health is a key driver of development, and it facilitates that development when all communities are included. Now, we've heard it said, and I will just acknowledge that COVID did impact all of us, and it impacted our priorities. It changed in many ways how we dealt with public health. In many ways, COVID subordinated public health challenges we had and our attempts to try to address them properly. But, as we've heard said, COVID is not an excuse. And so it is time for us to take on this challenge, to make sure that we deliver on that promise of committing to protect women's health, their rights, their privacy, that children and adolescents have access, that our family members in the LGBTQI+ community are included as well. There are strong headwinds, I think all of us will agree, trying to restrict rights and dignity, and those headwinds are strong, and they are organized, and they are certainly in the U.S. They are everywhere. But they are also stuck in the past. And that is where I think we have a chance to win. Because what we talk about today, especially our children, is the future. And for those who fight based on the past, they are doomed to fail and to lose. And so it is up to us to work to restore women's rights. In America, we could use your help, because we need to restore those rights to all women and girls in our own country, in the United States of America. We need to work together to try to undo things like what we saw happen in our own U.S. Supreme Court last year, where all of a sudden, women and girls who knew no different because they'd always lived a life having these rights no longer had them. We have a chance to make sure that we are protecting reproductive health care throughout the country of the United States of America. But what I can tell you is we are committed to protecting reproductive health care throughout the world. President Biden has made that very clear. And that is why, while we face challenges in the United States as a result of our Supreme Court, providing women with the health care that they need, all the programming, all the support, all the funding that we have committed to reproductive health care internationally remains in place. And the President is committed to make sure those programs continue to support worldwide women, girls, and families throughout the world. Sexual and reproductive health rights are not only a women's issue, but they also affect every one of us throughout our lives. SRHR are core to some of the most fundamental and important choices for any human being: who we love, how we form or grow a family, how we keep ourselves and our loved ones safe and healthy. And so we are all about advancing SRHR in the United States of America. We know it will be difficult. We know it'll be tough to fulfill that promise. And we know in the United States, the fuel is sometimes missing. The fuel is sometimes robbed, but we know we must succeed. And so I will say to you that it is time for us to, everyone, grip and push and be ready to fulfill that promise. On maternal health, I am fortunate to be joined by an expert in maternal health today, Dr. Carolina Reyes, who happens to be my wife. And so, as a high-risk OBGYN, I know she would agree, and I believe you would agree when I say that we have a maternal health crisis across the globe. In the United States, Black and Indigenous women suffer pregnancy-related deaths, many of them preventable, at a rate 3 times that of white women in our country, regardless of age and educational level. Our research confirms that areas of the United States that have banned or imposed the harshest restriction on abortion are also the most likely to lack geographic access to maternal health and to lack basic social family policies, such as making sure that new mothers can take paid time off of work to care for their babies. Tackling the maternal health crisis begins with understanding how institutional racism, economic inequality, and political extremism contribute to these high maternal mortality rates. No country is immune to these institutional challenges, but together we can better understand and pursue those solutions. And so I stand here to say to you that while in my country we face a challenge, in my country we have lost rights for so many in our nation. In our country, we face heated debate on where we will go in protecting women's health, women's rights, LGBTQ community rights. In my country, we have a president who is committed to making progress. And so I know we share interests, I know we share values in protecting and advancing health for all of our families. And I know, regardless of the challenges, we will deliver on that promise. I hope that working together, we will understand that no setback is permanent and that each setback will be in the past, as we know that we are about the future. Let those who are against us continue to live in the past. We're about making sure that our children learn that they have a right to have health care that they need. Thank you very much. I look forward to listening to the panel.
Thank you. Thank you very much, Bruce. Thank you for coming to the fueling station. Please take some fuel back home. Yeah? All right. Now we go to our panel. And today, you know, we've talked so much about the challenges, right? We've talked so much about where we are. It's good to talk about the solutions as well. What are we doing right? What can we copy from where? What can we transport from one country and use it, you know, in other countries for us to move as a unit? And I will start with you, Minister of Health for South Africa. Mr. Mathume, thank you so much for being here. And you know, Bruce talked about all this being a political agenda. Yes, we cannot talk about women, children, adolescent health and all these issues without politics. It's heavily political. And South Africa has been very instrumental in, you know, issues around leadership. You know, you've had a very clear role in the Global Leadership Network, championed by President Ramaphosa and supported by PMNCH. And we're talking about the forces, climate change, cost of living, the impact of COVID and conflicts. How is South Africa prioritizing issues around women, children, and adolescents in your national development plans?
Thank you very much. I hope this is on. Yeah. Okay. Okay. No, thanks a lot, and thanks for the opening remarks by our colleagues, the leadership of WHO, and also our colleague, Secretary of Health for the US. From South Africa, maybe let me not start with where we are now, just agreeing with the theme, talking about political leadership. I would say in our case, we're sort of lucky in the sense that from our advent of democracy, starting with the leadership of President Mandela, our late president, the founding president of democratic South Africa, he led from the front. And, you know, in a very amazing way, a bit of a shock tactic. Just a year into his presidency, assuming, I mean, remember, this is the man who's been 27 years in prison, away from society, comes back, leads the negotiation to transition, takes over. He's never run a government. At the most, he's run a prison cell for 27 years. And within a year of his presidency, gave an executive order to say all pregnant women will have free services at all public health facilities. And also said the same for children under the age of 6. They must receive free health services. So that was basically the foundation of, our trajectory in terms of where to go. So I would say he sort of was a pathfinder, and all subsequent leaders of the country had to improve on that in terms of now providing improvement of quality. And of course, coming to the present, our current president, maybe because he's also somebody who worked very closely with President Mandela during the negotiations. He was his right-hand man leading the negotiations. So he's also, coming very forcefully into that. As you would know, has accepted the request from the PMNCH to lead the Global Leaders Network. So he's talking to a number of leaders of the world to support this work. On a country level, a number of initiatives based on that executive direction by our founding president to improve now the quality of services, make sure that progressively we address the challenges of quality. A lot of progress has been made in terms of when you look at the outcomes, whether we talk about maternal mortality ratio over the years. There's been a lot of improvement. Of course, at some stage when the HIV epidemic was hitting quite hard before we were able to roll out the HIV antiretroviral treatment, that also was having a huge impact. At some stage, we're sitting just on maternal mortality ratio just under 300 per 100,000, 270, 80. Just before COVID, we had just below 100. And there was a bit of reversal over the last 2 years of COVID, but we're busy catching up. So there's a number of programs. I won't go into the details. I'm sure as we discuss further, one can touch on that in terms of improving the maternity services, improving on the children's side, childhood immunization programs, which were also suffered a reversal as a result of lockdowns and access to services from COVID. And the consequence of which has been that in the last few months, from the end of last year, we started to see outbreaks of measles amongst children who had not been vaccinated as a result of the pandemic. Just recently, there was also a few outbreaks of mumps, and also before I left, just a few days ago, there was a few cases of diphtheria, which were also identified. So we have to, again, ramp up in terms of childhood vaccination. But I must say that the foundation has been laid. All that we're grappling with now, it's making sure that there can be an improvement of quality. But just to say, some of the unintended difficulties, of course, is that as you open up and make services free, you have to make sure that also as more women come forward to use those services, you're able to provide the necessary human resources, the necessary facilities, necessary equipment, necessary commodities. But a further complication for us has been with the challenges of economies, not only in our country, but in some of our neighboring states, where you now, over the last few years, it has been rising, and it's a major debate of what then we need to do with our fellow neighbors, where you find in some of the neighboring countries where, because some of those countries still charge for services. So you find women from neighboring countries basically coming to South Africa to seek maternal services because it's free. And of course, in that process, get crowding, people start to be unhappy and so on. But it's something which we again, on the basis of political leadership, it's up to now as the political leaders to say, how do we engage our colleagues in other countries? So maybe let me just stop there to say I agree that political leadership plays a very important role, and of course, but you must back it up with the necessary planning, necessary technical support in terms of health infrastructure, but also all the various support, especially the human resources, the professionals, the midwives, the doctors, and all that. Thank you very much.
Thank you. And probably human resources is a very good place for you to end that. And this takes me to, Liberia, where earlier this year, the Monrovia Call to Action was launched, which actually calls for an increased investment in community health workers and programs to just ensure that UHC and primary health care is improved, right? So, Minister of Health for Liberia, Ms. Wilhelmina, what do you think really stands out in the Monrovia Call to Action?
Thank you, Madam Moderator. To our keynote speaker, or the director, or the other ministers here, ladies and gentlemen, I always like to give you a picture of what's happening in the country before I go into to answering the question. You know, Liberia is on the west coast of Africa. 5.2 million people live there, or 2 million lives in the urban area. 1.5 million people live in 5 kilometers away from the nearest health facility. We have a little over 4,000 community health workers. We have about 500 community health service supervisors, and we have about 5,000 community health promoters. Community health workers over the years have really been the front line. And reason for call to action, we wanted to recognize them. These are individuals that are selected by their communities. So therefore, the community trusts them. And also, they provide basic services at the community level. They take care of the mothers, they make sure that they make it to the antenatal care, they make sure that they go to the facility to deliver. Also, they make sure they treat malaria and other things. But we recognize them, most importantly, during the Ebola, they were there in the community making sure that people were safe. During the COVID-19, they were there making sure that people were safe, bringing health promotion, making sure people practice what they needed to practice to provide the protection that they needed. They also were there for us to be able to obtain the high number of vaccine coverage that Liberia were able to cover. So these are people that we need to recognize. So this Monrovia Call to Action wanted the 46 countries that were there, wanted us to bring them to a higher level, recognize the kind of work they are doing to make sure maternal mortality is reduced, infant mortality, family planning, all of these things are going up. But they are underpaid and they are not recognized. So the call to action was to call partners, call health ministers, call finance ministers, all those who are in the vineyard to support them. They need more education. They need to be supported financially because in a lot of countries, community health workers are not paid. They are doing volunteer work. And in order for you put so much on their plate, you wanted to recognize non-communicable disease. You wanted them to be involved in making sure that women, children, and adolescents are following the promise that we made them, but yet you don't want to do anything for them. So the call to action, we're calling all of us to make sure that we support community health workers, because they too have to live as they help us to live better. Thank you.
Thank you. And not calling them volunteers anymore, right? And not calling them volunteers but workers.
They are part of the health system, and if we begin to recognize them as part of the health system, then they will be better off, and we'll take away the title volunteer. No longer they will be volunteer.
Thank you very much, Minister Jala. Now, we talk about the health and well-being of women, children, and adolescents, and we talk about, you talk about Ebola, which was a big crisis. We talk about COVID-19, it was a big crisis. And now, another thing we cannot really avoid is the climate change. And the Horn of Africa, which is my home, and the home to Minister of Health for Ethiopia, Leah today says, well, Ethiopia has been going through, the longest drought that we have had in 40 years. The effects have just been, it's been overwhelming. It's taken a big, big toll on our health systems. It's really brought out, the glaring iniquities that probably we had not realized, and that were exacerbated by COVID and now climate change. And Leah, I'm really interested in just getting your perspective on, what are the critical elements, especially when it comes to SRHR, sexual and reproductive health and rights, and maternal and newborn child health, when we are responding to such crises. Because, everybody talks about food and water, and we bring that in medical aid, but what about the other components?
Thank you very much. Again, thank you, PMSH and all, for coordinating this to really challenge ourselves on where we are on the promises. And as was mentioned by all speakers, these inequities and inequalities, of course, existed before the many recent challenges we've had as a country, as a globe. And of course, we all recognize also, I think it's important to recognize the investments before that and the progresses, but definitely progresses that we cannot all be proud of. And of course, the challenge, the inequities that have been exposed more, and the past few years, as my sister Mercy mentioned, in addition to the pandemic and the key challenge of climate change, which we have been as a country facing, but in addition, of course, conflict was also another major setback, which has, again, with displacements and impacts disproportionately, again, on women and children. But what we have learned, I think, of course, the investments that we have done on primary health care, even if those shocks have exposed and really brought a big, big challenge, the investments that we have done on primary health care has also given us some resilience to overcome some, in a way, these challenges, to sustain some of our services and quickly regain. In the COVID pandemic, disruption of essential services was a key challenge, but regaining them quickly to provide the services needed happened because investments were made on the primary healthcare system. And I want to highlight a few points on that. That's also the same when we talk to all the different challenges that we are facing now. So it has shown us really that we need to continue really the increased investments on primary healthcare. But what do we mean by that? One is what we have done before and what we are relooking now is, of course, it's not about just accessing. Well, of course, the first investment is the infrastructure has to be there, of course. So our community, just like my colleague minister from Liberia mentioned, a lot of investment in Ethiopia had happened on community health workforce, as mentioned, as part of the health system, salaried by government. So that was a key pillar for our country, which has impacted our maternal and child mortality. But there are community health workers providing limited services. They are not providing all the delivery service that we need. And when complicated, even at primary healthcare center, we need to still refer women for better care. So the investment has to be at all layers. So the primary healthcare system, the primary health centers, which provide 3/4 of the deliveries, the skilled delivery attendance has grown in the past decades, but 3/4 still delivered in primary healthcare centers, which cannot provide emergency C-section if it's required. So really investing on primary hospitals, and recently what we have done was investing on building operation theater blocks within primary healthcare centers so that at least some segment of our primary healthcare centers can provide this care to mothers and neonates in a very short time, as needed to really limit the morbidity. And revisiting our community health workforce or health extension program, we also looked at although it has brought us to reduce around 72% of mortality since the investment on health extension program in the last 17 years, we needed to revisit where we are. The demand from communities, awareness has increased, and the care that we need to provide at those levels has to expand. So we have a new roadmap which converts around 13% of our health posts, which are far from the nearest primary health care center, to upgrade their package of services with delivery services included, but it requires, again, more investments in terms of infrastructure, health workforce expansion in terms of the packages. So it's about health workforce, it's about infrastructure, equipping, but also about having a very strong referral networking and support system between primary hospitals to health centers to health posts, where we have this mentorship program, and also putting in standard guidelines in place so that what the services we deliver across the board are up to the standard. But ultimately, it's about the financing. Because when we have been rolling this out, but the pace is not as much as we want because of resources. So, of course, when we are talking about financing, one is we need to continue to increase investment by government. That has been always a challenge. We have, of course, progressively increasing government investment to health for us as a country, but it's not yet enough. It's not yet where we have at least a minimum we have put together with the Abuja Declaration. So we have a long way to go. But we cannot only wait for that. That's one thing we continuously advocate, and it's increasing. We work closely with the parliament. And of course, we are a federal country, so it's not just about the national level, but at some national and all the way. And I have my colleagues from some national health bureau heads also with me. So that's one of our challenges. We try to push at all levels. And the other is to look at different ways of innovative financing to increase the domestic resources. So one is rolling out our health insurance system and looking at other modalities of really increasing the health financing. But here I want to mention that, of course, for these key maternal and newborn services, family planning, immunization, which are really top cost-effective interventions, as we all know, we have been providing those as exempted services, especially for, of course, for immunization and family planning. That has been for many years, and also for maternal health and newborn health. That has been there for about 7-8 years as a country, in a movement that we call No Mother Should Die While Giving Birth. So it has been an exempted service, but it is not really easy to maintain this. Our system has been challenged now to really maintain the exempted services. So we are looking at how do we, what I mentioned earlier, how do we get more domestic resources, increased government investment, and increased donor funds to align and continue investing on those services. And one last thing I would like to mention is the alignment needed by donor funds, ultimately at the country level. And we've been doing a lot of efforts. One good example is we have got a commodity shortage for family planning, which is an exempted service, which we cannot disrupt, a key intervention for mothers, be it in conflict, be it in displacement or routinely. So now we're working with donors to have a compact where different donors would fund, but government would match this fund. So it increases domestic or government commitments, but also brings alignment of the different donor resources that we need. So I hope these kinds of platform by PMSH can help us to bring this more forward. Sorry if I took time, thank you.
Money, 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 money and funding, and I'm so happy. You know, one thing I've noted is that everybody on this panel has talked about investment in a way, has talked about more resources, has talked about funding. And I know it's something we need to discuss, and I'm happy that that's the last thing we need to talk about, because those money conversations are just the best to always have. But before we go there, it's always really wonderful to have a young person in a panel, because their perspective of things is just beautiful. And Mariam, I'm really keen to hear what you have to say about this. You are a fifth-year medical student. Take the mic.
I'm not sure if it's...
Yeah,
yes,
what?
This one's working.
How are you feeling?
Good.
Good?
Yeah.
Bored?
Nervous a bit, but good.
Oh. Happy to be here?
Yeah, very happy, very pleased to be here. Thank you so much.
Oh, great. So probably you have a few more months to go before you get into the pits, into all this, and really getting your hands dirty. Are you ready?
Yeah, I'm ready.
To come into a field, you know, when everything is just, you know? Do you feel like, as a young health professional, that you have been recognized in all that we are talking about, and that this world is ready for your skills?
Thank you so much, Mercy, for giving me the floor, and many thanks to PMNCH for inviting me here. For me, it's a pleasure, but also a responsibility to be here speaking on behalf of the youth that are privileged enough to make it, but also those who aren't privileged enough to make it here in Geneva. I would be touching upon two aspects of your question. The first of which would be the role that young people and young healthcare professionals play in championing the needs of WCAs. And the second aspect would be the vital importance of prioritizing the health of WCAs in humanitarian settings, as I am the liaison officer for human rights and peace issues. So as we all know, youth make up to 16% of the global population, which makes us a huge demographic group, and which is why it is very important to bring us into these spaces where these different topics are being discussed. So we have a huge potential to shape a better and healthier future for all. We bring the creativity, we bring the fresh perspectives and ideas into the discussion. And so we need to be equal partners in the decision-making processes. This is the first aspect of it. As some of you might already know, and as I was speaking to Ilse today at the IFMSA, because we practice what we preach, before the WHA, we have the Youth Pre-WHA program where we bring the finest delegation of our network of 1.5 million medical students worldwide, and we better shape their skills and broaden their knowledge on the topic of several topics of global health advocacy. That is the first aspect of it. Now, the second aspect of it is that the importance of touching upon this topic does not only come from the promise of youth, but also the urgency of the topic itself. With the complications of pregnancy standing today as still the first, as you said, Mercy, earlier, still the leading cause of death in women worldwide, this topic demands further attention from us and also a call for swift action. So that brings me to the aspect of why is it important to prioritize the health of women, children, and adolescents' health in humanitarian settings. In humanitarian settings, beyond the aspect of the exacerbation of the health of all populations and the distress that is brought into the country, like that is being touched by the humanitarian setting, this vulnerable group is seeing further exacerbation of all their rights, but also the healthcare setting itself, which is why it is important to bring us as youth into the table to also bring our perspectives, but also take put this this group of women, children, and adolescents into the spot in order to discuss their health and find solutions that are adequate to the problem when we speak about the humanitarian settings themselves. I will cut it short for the sake of time. Over and back to you, Bessie. Thank you.
Thank you very much. Like I said, it's always very interesting to listen to the young people. Did you hear her say that they brought the finest delegation of young people? That's what she said, and definitely she's one of them. So yes, in the interest of time, I will not ask further questions because I know we have an hour after this for us to interact and ask each other questions and all that. And we cannot end this without talking about money. Look, it's really good to end with you. All of these people have talked about money, have talked about investment, have talked about funding, have talked about donors. My goodness, I don't envy you. Yeah, because you play such a very big role in all this at the GFF, you know, and we are now at a time when, you know, the spending is just like we need more money. And you have a big role to play in mobilizing resources, you know, coordinating actions and just advocating at the highest level. What has been your biggest challenge, especially when we talk around COVID and climate change and now crisis? How are you faring on?
Thanks a lot, Mercy, for this introduction, but also thank you for to a keynote speaker for and to the Deputy Director for WHO and for Elga, of course, to set the stage for the sense of urgency. I think we definitely share that sense of urgency. And yeah, lots of weight on the shoulders, but actually the GFF is a global partnership, so it's all of us in this. We are anchored at the World Bank, but it's a country-led partnership. The country leadership is really at the core of it. Currently supporting 36 countries with an aim of reaching 50 over time. Some of the poorest and most fragile countries. So about a third of the countries are actually currently in situations of conflict or fragility. So really starting with the hardest in a way. It focuses on supporting countries to develop prioritized plans that are based on evidence, so ensuring that the money that is there is actually being used in the most efficient way possible. We heard Minister Tedesse, for example, talk about their plan. This is the plan we support. They're nationally developed plans, and depending on the type of support that the country needs, in developing those plans, we adjust accordingly the technical assistance that's provided. There's a strong focus on growing the domestic resources. Those domestic resources, there's an analysis that the World Bank carried out during the COVID period that is not terribly promising. It's showing that the fiscal space is not very promising in several of the poorest countries, but some of them do have growth prospects and there is space there. We're also finding that having, and ministers on the panel can speak to this better than I can, but for ministers of health in these countries to have really credible plans with lots of external alignment to them or against them, aligned to them, yes, makes it more credible when they're making their budget asks to finance. And so there's that element there that also works. We're housed at the World Bank, and that enables us to use the grant financing that we get from donors to match with one source of domestic financing, which is the World Bank envelope that countries get. They decide which sectors to allocate. The ministers of finance or planning generally decide. And it's not a given that it would go to health. But what we do is we say, okay, there's a 10, 20, $30 million grant here that if matched to IDA, if goes to the health sector, could be matched to the IDA. Increasingly, we're also working with some other sectors such as social protection to enable a sharper targeting of poverty and so forth. And there's a package of technical assistance that's also provided, and then this support to the alignment of external partners. Some of the challenges, as I've mentioned, the fiscal space, but also, you know, as I was listening and hearing the sort of sense of urgency and how we need to be doing things differently. I think one way in which we need to work differently is really, really double down on equity. And I know that a number of the agencies are working on this, and the governments, of course, and we've done a good job, I think, of targeting geographically, but then let's really look at what happens within those regions and see what we can do. Still some challenges around aligning at country level. Minister Tadesse spoke about it. But I'm actually quite optimistic, because it's true that the trends are not very encouraging in terms of the flattening, and we really share that sense of urgency. But actually, when we look at the GFF supported countries and compare them to similar countries that are not yet benefiting from that support, there's more rapid improvement of coverage of services, quality, etc. So when you pull together these different pieces, it really can work. The results are emerging. I'm also very encouraged by the role that civil society can play in countries, and especially and including in mobilizing domestic resources. I remember being based in DRC and watching the budget process that particular year, and there was virtually no money being allocated to health. And then at one of the consultation stages, civil society really, a very organized civil society, made a strong case, and it unblocked considerable resources, domestic resources for health. So I think there are a number of areas we can all work on. You know, I could go on, but public financial management is another one where we support. It creates the credibility for allocations to the health sector within the budget, but also for external alignment. Thank you.
Thank you, Luke. And as the last speaker in this panel, and probably I'll do this for the rest of the panelists, I know we are on this stage talking about our countries and what we are doing as governments, as organizations, but I'm really interested to know, and I'm sorry to put you on the spot, what you are doing in your individual capacity when you're not speaking for your organization, in your social settings, for women, children, and adolescent health and rights. Look. Yes?
Sorry, I thought you were turning to the ministers.
No, I'll start with you.
What I'm doing in my individual capacity.
Yes.
For me, it's, in my individual capacity, it's also related to my job. It's to really think, to spend extra time thinking about how we maximize this model.
All right, thank you. Honorable Leah, what are you doing in your individual capacity when you're not speaking for the government of the federal government of Ethiopia?
Well, because it's a tough question. I don't know if I have an individual capacity separately. Maybe at my home, yes.
Yes, at your home, that's acceptable. I will accept what you're doing at home. I understand you're trying to be diplomatic here, but I will take what you're doing at home.
No, well, of course, in any way, I used to be also an obstetrician gynecologist. I say used to because I don't practice now. So this is something very close to me, and as a woman leader also, it's something very close to me. So, I mean, in any opportunity, be it an individual person that I meet who needs help, a woman who needs help in any way, it starts from supporting that individual initiatives there are individuals or local NGOs who are really working hard with very limited resources to support women and children. So it could be related to supporting those, and of course, to make sure that my ultimate responsibility of my own family is also met as I'm running around to do all those things.
Thank you very much, and I'm sorry for a tough question. Honorable Mathuem, very briefly, what are you doing in your individual capacity when you're not speaking for the government of South Africa?
Well, I must agree with my colleague and neighbor here that you see in our positions, sometimes you get so much absorbed into this that you hardly have any private life. But it all gets so much intertwined. But I would say one tries to use, whatever opportunity, to network, overall as a social activist. Make sure that network with the relevant people, not specifically in terms of the portfolio, but as a political, social activists, find the right people, network to make sure that you can continue to make an impact, not just in your portfolio, but in improving people's lives ordinarily, without necessarily in your official capacity. That's what one tries to do. Thank you.
Honorable Jaller.
Well, I spend my time speaking to churches or women's group about breast and cervical cancer, because that's close to my heart, making sure that we prevent breast, because we have a high number of women that they do not even understand the wait until it's late. So I spend that time doing that. And I also spend time working with girls who had their first pregnancy, but trying to prevent them from the second pregnancy. So you educate them, you talk to them, you find ways and means for them to be able to do other things. And that helps them to not get a second pregnancy too early.
Wonderful. Thank you very much. Mariam.
Okay, thank you so much, Mercy. This is a really good question to also gain perspective and always remember that we need to do this advocacy beyond what we work in So what I do to champion the health of women, children, and adolescents in general is at the very core of what I do right now. So I'm still a medical student. So as a young healthcare professional and as a still very fresh practitioner, the day-to-day care and the interaction with the patients gives me the pleasure and also the responsibility to educate the patients at the OBGYN, in my OBGYN rotations or else. But I also do day-to-day advocacy with peer-to-peer education, with also spreading the information to my fellow colleagues as well, which I think is also of very paramount importance to keep the information spreading and to keep the change sustainable as well. Thank you so much.
Thank you very much, ladies and gentlemen. That marks the end of our panel discussion. I know there might be questions from you. Oh my goodness, there's a hand there and a hand there. I'm so sorry, but I have to wrap this up. But I want to promise, 1, 2, 3, those are 3 questions. Oh my God, 4, 5. My goodness, I am embarrassed that I didn't have a slot in this program for questions, but I promise you, listen, we have a whole hour after this for all these people. None of them is leaving this room. None of them is leaving this room, and you can walk up to me and ask me to take you to them because they're going to answer all your questions. It's just that I'm not going to hand over the mic to you because we need to close this and interact and know how we are doing in our individual capacities. So yes, please, dear panelists, you saw those hands. You have a big task ahead, so do not leave this room. Please, allow me to close this first part of our program, and then we move to the reception. And to do that, please welcome on stage Gidinje Gitahi. Doc, co-chair Strategic Advocacy Committee PMNCH and Global CEO of AmRef Health Africa, and a fellow Kenyan. Welcome on stage, Dr. Ray.
Well, well, well. Ted, I was supposed to speak after you, but I guess, no. I think Marcel looked at hierarchy and protocol here and said, no, no, no. Okay. No, thank you very much. And I think Ted and I are actually between you and the cocktails. But every extra word we speak is reducing the amount of wine you're going to have, which is a good thing for your health. So look at it that way. Yeah. Hi, Marcel. How are you?
Hi, I'm good.
Good
I'm
to
not
see
doing
you.
Too well today.
Good to see you. No, you're doing very well. So let me just make a few remarks before Ted comes up. The first thing I would say is there's a striking statement that I saw in a DEVEX report recently, and they were interviewing people, and I think one statement caught me by a woman called Treasure. Treasure had lost her child, and Treasure said, "I feel angry. I spent a lot of time reading about and preparing for motherhood, but I didn't really think about the possibility that my baby could die. I just assumed if there was something wrong, then a doctor could fix it." That's the amount of trust the communities put in our health systems. They say there's a health system, we trust it. But then 800 women still die every day, and 14,000 under 5 children die every day. 14,000. We're here to discuss women, children, adolescents, so we can talk about numbers and data. I'm sure you have them ringing out of your ears. And we were told earlier, so we don't have to repeat those. But this is the challenge. The challenge is that we have failed to meet the trust the communities have for us. So I just want to say a few things here. Number one, when you talk about women, children, and adolescents, their lives are intertwined. They're actually interrelated. They're inseparable. So the survival of under fives, the better health for adolescents, the lives and saving the lives of women while they are giving birth or during that process, they are intertwined. I look at my mother, she gave birth to 9 children. 9. I'm number 8. Can you imagine? And I have my white hair, I'm number 8. And I think that if my mother had passed on during my delivery, my chance of death would have gone up 50 times. So I survived because my mother survived. So they are intertwined. Number 2, remember that teenage pregnancies are more likely to lead to maternal mortality than non-teenage pregnancies. So they're all related. So everything we're doing here is related. And of course, if a teenage pregnancy ends up in mortality, the child of that teenage girl has a 50% or 50 times higher risk of death. So it's all related. This therefore means that as PMNCH, our strategy, our advocacy, and our key message is to ensure that we have policies, service delivery, and financing that resolve this problem for women, children, and adolescents. It's that simple. Policy, service delivery, and financing, which I have talked about here, that is responsive to this problem. However, Treasure, who I told you about just a minute ago, representing all women that lack access to services somewhere in the world, lives in a family, in a household, in a community. So whatever we do here, as Mercy said, is just a fueling station. It is like a dessert. The main course is actually out there where we are going. The work we do, therefore, must ask how it can impact that lowest denominator where Treasure lives. That's what should be in our minds as we leave this room and as we go back where we are going. The lowest common denominator, the household, the community level where Treasure lives. And our work must reflect on the value of the commitments we all make, the ones we accept from governments. The ministers are here. They give us commitments. We record them on our website. How reflective are those commitments to where treasure lives? Allow me to make 3 years as I close. One, that whatever we do from here moving forward, because they're looking at the future, and Mercy told us we failed, and it is true we failed. When I look at the declaration of UHC 2019, and now we are deliberating the next declaration in September, which we just had the multi-stakeholder hearing for, I can't fail to reflect on the fact that that particular declaration, I feel, has not moved issues forward. The question is, what do we do about this new one? So actionable commitments. Secondly, alignment to the country programs. On these two, actionable commitments, country, national alignment, in between there is Parliament. Is Parliament, and we must think about the legislative role at country level. But that role must be driven by actionable commitments that we can give to our members of Parliament. Because somebody told me during the notice hearing that real love is shown in budgets. And I would like to add equitable budgets, as was said at the end. Real love is shown in equitable budgets. The other point is working together. I just came out of Madrid. There was a big meeting on childhood pneumonia. And the team there was talking about childhood survival. And they said, we need to work together. PMNCH and all of us and GFF are working on survival. How do we make sure that we take our dollar further by working together? So we must work together with the national governments, with the communities, with CSOs, and with everyone else who is in this ecosystem. Let me remind you that the challenge is difficult. In Africa, where the chance or the risk of death for under 5 is 15 times more than the high-income countries, in Africa, where actually more than 500 women die daily out of the 800, the available health budget from the public, on average, I won't talk about South Africa, it's a little more advanced than most others, is $50 per capita per year. $50. And that's assuming good collection, good allocation to health at 15%. $50 when a government is behaving well is what you get. Can you imagine in OECD it's $4,000. So we have a $4,000 problem, and of course in the US it's different. It's $10,000. I see my friend Lois Pace here. You're talking government money, $5,000 what is available. We still have inequities with women dying and the black ones dying even more. But Africa is dealing with a $4,000, $5,000 problem per capita with $40 available. So we must talk about working together, efficiency, and that must be what we drive for. In-country working together, actionable commitments involving legislative agenda so that we codify everything that we say we want to be done. Country, country, country. Action, action, action. And working together without competition. I hope that the fuel you get here today is not fossil fuel, but is renewable energy. Thank you very much.
Thank you very much. Thank you very much, Doc. And Doc, also, real love is also shown based on who is allowed to be the last man standing. And I'm so sorry I took that opportunity away from you. So, Ted Chaiban, you get the honors of giving the final comments and telling us about the lessons that we have learned and how we move on from here, and opening the reception.
Thank you, Marcy. I'll try to be brief so we can open the reception. And thanks to PMNCH and to all of you for everything you do for health. We've gone through so much, and it's really important to not forget what we've gone through, both what's been good and what's been bad. And I think in terms of what's been good, we need to remember that in the midst of all the chaos and devastation of the COVID-19 pandemic, we also saw some unprecedented responses. And the fastest development and deployment of a vaccine that's ever been done in mankind's history was done with the development of the COVID-19 vaccine, with over 16.1 billion doses of COVID-19 vaccines deployed globally, including through COVAX and AVAT and other mechanisms. At the same time, the pandemic response exposed some serious structural inequities. And where we went wrong was when we forgot that health is a human right, and that, as Dr. Tedros reminded us earlier, where you're born, where you are a child, an adolescent of a woman or a woman should not be a determinant of whether or not you have a right to health. And we cannot let our commitment to that right wane. There's just too much at stake. You know, several of the speakers have spoken about, given different statistics. Let me just put a couple of more numbers on the table. You know, progress to keep women and babies alive has stalled, with a combined 4.5 million maternal and newborn deaths and stillbirth occurring each year. Between 2019 and 2021, nearly 67 million children are estimated to have missed out on routine vaccines. So we need to recommit to seeing health as a right and to keeping the promise and to getting back on track. And in order to do so, there are a number of lessons from the COVID-19 response that we need to take forward. Firstly, is the need to decentralize the means of production and support regional manufacturing. We cannot have manufacturing in the hands of the few. We need to have manufacturing in Africa and Asia and in places where it can be equitably accessed. Second, as the panel has said, and I want to refer here specifically to our minister from Liberia, we need to invest in strong community-based primary healthcare systems with paid and protected community health workers that have a career pathway, that have supportive supervision, and that are trained. There's simply no road to either universal health coverage or to pandemic preparedness and response which does not go through primary health care. Third, we need to focus operationally on the last mile. There was a lot of attention on supply, but not enough on delivery at the last mile. And that involves issues of dialogue, issues of trust. I remember a few months ago being in Sudan, in Darfur. Sadly, Sudan is going through a terrible situation now, and speaking to a woman in displaced camp, and she told me, I will trust the vaccine when it's delivered to me by the health worker who takes care of my children day in, day out, and who lives in my community. So we need to look at those issues of last mile delivery. And lastly, we need to be country grounded. We need to be grounded on plans that are country owned, one plan, one budget, one team, which is led by government and its partners, break through the verticality of how we often work in health in order to support that plan, and ground all of our regional and global support in the multilateral system. So those are a few of the things that if we get right, we can get back onto the promise, we can get back on track with our health. As we move forward, please count on UNICEF to be a key partner and to work with you. Thank you very much.
Thank you. Thank you very much, Ted. Thank you very much, Dr. Gedinji, for closing the session for us. And that brings us to the end of the first part of this. And now for the whining and the nibbles and everything in between. So please feel free to interact as much as we can. Like we said, it's a fuel station. I know the people who raise their hands because they have questions are looking at me in a way to suggest that they'll probably kill me when I step out of this room. I am, oh my goodness, this is not, who do you want to answer your question? Oh my, oh, that's a lot to take. So you know what I'll do? It's just one question. You're the first one to go, and I will bring you to the ministers myself, okay? Thank you very much, ladies and gentlemen. It was a pleasure hosting you here. Those of us who converged online, thank you so much. Please feel free to step out, have something to bite, have something to drink, and ask the tough questions to this panel and to each other. Thank you very much, and see you tomorrow for the second Lives in the Balance.